And I'll turn it over to you, Stephanie.
Sounds good. Thank you. Everyone, I'm Stephanie Bennington. I'm a psychiatrist. And I apologize. I like everybody else here. I'm sure everybody's getting over some type of sickness. I still am. So my voice may go in and out. Apologize in advance, but a psychiatrist was located in Omaha, recently relocated to Western Nebraska, but I also kind of do a little bit in Wyoming and now also Montana. So I kind of have a broad little location. Actually, I shouldn't say broad, I should say a kind of expansive location base here. Let me go ahead and share my screen. Okay, and tell me if you guys can see this. Good. Okay.
Yep, it looks good.
Okay. All right. So today I'm going to be talking about some of the off-label medications that we can use for treating substance use disorders. There's kind of an expansive list that we could go into. I kind of narrowed it down by type of medication and kind of just briefly overview, discuss some of the research on whether or not we should use it. But ultimately, it kind of comes down to the individual patient, their substance use disorder, and ultimately all of the other factors going on in their life. And we'll kind of discuss this more. I hope to be able to get done with enough time that we can discuss like a patient case anybody has. I also wanted to discuss some of more of the novel treatments that we haven't been able to use yet, that research is currently ongoing. In a project that I'm actively working on, hopefully getting started. And we'll kind of get into that a little bit more here. So some things we'll kind of discuss, as I mentioned, we'll talk about off-label. Some of this will kind of seem elementary, but I like to go into the small details initially because this can have an important implication, especially in legal consideration. So I like to make sure that we even kind of go through like basic definitions, things like that, and then go through like scope of presentation of like discussing with patients, how to go about and figuring out if a certain medication is right for that individual patient, how to go about and discussing that with the patient to make sure documentation is there and any possible legal ethical considerations have been met. So just kind of start, the first thing when we're all thinking about how we're treating anything is, is the diagnostic criteria, right? So really understanding what your patient is using is key here. Um, Most of the time they have a primary substance of choice, right? Whether it be alcohol, opioids, stimulants, et cetera. But sometimes you also have a lot of patients using a combination. But ultimately, when you kind of ask them if there's a substance of choice, generally there is, but not always. And so I just wanted to make a note of that. That's not always the case. And as everybody here, if you've listened to my previous lectures, everybody knows I'm a huge advocate for ADHD and substance use in general. And I've discussed this prior, and I can always do presentation on this afterward as well at a different point. But a lot of the patients that maybe don't necessarily have a substance of choice, though for those individuals, I commonly will really look at evaluating them for ADHD and things like that. But that's kind of a side topic. Um, so when we're looking at the research, like why do we want to look into this, right? Like why do we want to do off-label prescribing for substance use disorder? And it really comes down to like the impact on, of course, the individual and our healthcare systems. Um, there's a lot of challenges in our standard treatment protocols, and we simply don't have a lot of medications that have been approved for substance use disorders because the research just isn't there to really support it. And so a lot of the treatments that we do use are actually off-label. Some not, but a lot of them are. So we'll kind of discuss this a bit more. One of the classes of medications that we can look at for treating is our antidepressants, and I commonly see this use. And I think the idea around it is more because it's a safe medication, and a lot of times there is that underlying depression or anxiety, and perhaps that came first, and maybe that is what triggered the substance use disorder. And so this is where it really is important to truly understand where patients are at and where they were at before the substance use disorder came into play. When we look at the research, there's been quite a bit of research on our antidepressants on using them to treat substance use disorder. And 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 disappointingly, the research isn't really there to support solely the substance use disorder as a primary treatment. Where the research does show some benefit is with selective serotonin reuptake inhibitors or SSRIs. There is some potential in alcohol use disorder, but again, the research is simply there's just not enough. But the trials have been positive. Some of the trials have been positive. Bupropion, that's our dopaminergic and noradrenergic effects. We use it, of course, in tobacco use disorder. That's all Wellbutrin. Mirtazapine is one of the medications that I'm commonly looking into seeing what new medication or what new research trials have been done on this medication because I feel like there's a lot of potential for this, but again, we just don't have enough trials to support it. But we do get the modulation of both the serotonin and norepinephrine neurotransmitters that can help with some of the substance use disorders. And as I said multiple times now, our research is just limited for overall general substance use disorder, and it's just not it's not quite solid enough to actually say, hey, this is what we need to do. And so this is why it's exceptionally important. Take the individual patient into account, really understand their situation, before the substances came into play and figure out what it is that they actually need in order to adequately treat their substance use disorder. Anticonvulsants are another commonly studied group of medications, and some of the research actually is good. It's supportive, still limited though. Gabapentin, just kind of a little background. I kind of give a brief little overview of the mechanism of action of each, just to kind of remind us of what it does. But gabapentin modulates the calcium channels. It does have a role in alcohol and opioid use disorders. There is positive research to support the use. Topiramate, GABAergic and glutamatergic effects in alcohol dependence. Alvalproate or Depakote, there is limited evidence in managing our withdrawal symptoms, and not necessarily for the actual treatment, but the withdrawal symptoms, which is equally important here. I mean, if patients are withdrawing and those symptoms are not adequately treated, the odds of actually treating their substance use disorder are extremely low. If a patient feels very, very crummy, the odds of them going back to use to alleviate those symptoms are quite high. So overall, our anticonvulsant class, the research is promising, which is great, right? We need a lot more research to support this. It is promising, but again, we just need further studies to support it and to get kind of those guidelines changed. Again, so next one, antipsychotics, but again, limited use simply because the research isn't there. But I always like to kind of mention a few that if we ever do need them in substance use, these are the ones that have been studied. So we have some trials on aripiprazole, Abilify to look at treating specifically our stimulant use disorders, where a lot of times where it can come into play is during especially withdrawal.
Hey, it looks like we lost Dr. Bennington there. She may have lost connection. Let me sit tight for a minute and let me see if I can communicate with her to get her back on.
Goodness, I apologize,
Hey,
everyone. I guess I got kicked out. And
no
I was
problem. Yeah.
let me go back here. I gotta reshare it. I'm just not having luck with computers today. Okay, let me
It
do that.
happens.
All right. Can you see
Looks
it?
good. Yep.
Okay. All right. Fingers crossed that no more issues. Okay. I think I left off. I had already kind of mentioned Abilify, investigated in stimulant use disorders. It can be effective, especially in the withdrawal period. Seroquel, quetiapine, it's got some sedative properties both for alcohol and cannabis use disorders. Again, we're kind of treating a lot of the secondary symptoms. The research again isn't really supportive for actually treating the substance use disorder itself, but we can get, especially that withdrawal period, we can get a lot of the alleviation of some of those symptoms. Risperidone, again, minimal evidence for substance use disorder efficacy, really just kind of using it as an adjunct for managing those symptoms. For our opioid use disorder, this is probably one of the most studied areas. Also why kind of the funding is there for our ECHO projects in general is, this is such a widespread issue throughout the United States, especially with opioid prescribing and things like that. So we have quite a bit more research on opioid use disorder in general. But some of the non-traditional medications that have been studied are clonidine, especially. This is now kind of a standard protocol that we use off-label, specifically in the withdrawal period because of the alpha-2 adrenergic agonist effect. Um, when patients come off opioids in that withdrawal period, I guess let me rewind a little bit to kind of give a bit of a background. But while a patient is actively on and taking opioids every day, we get this block of norepinephrine, and we get this increase of the dopamine, and that kind of has a downstream effect of kind of limiting the release of the norepinephrine. So when we take away the opioid and patients stop actively taking it every day, we get the decrease in the release of dopamine, but as a result, we get that blockade of the norepinephrine that turns off, and so we get this rush of norepinephrine released into the synapse. And when that happens, that causes a lot of the terrible feelings that patients feel when they come off opioids. I mean, a lot of them describe it feels like I'm dying, and that's absolutely true because of that norepinephrine surge that happens. I mean, if a patient was running from a bear or was trying to survive, I mean, it's the similar response in that norepinephrine surge, that fight or flight that we all know, that studied the fight or flight mechanism. That's what happens, and that's what is unblocked when patients abruptly stop opioids. And so really kind of looking at medications that can alleviate those symptoms and that can increase the success that they'd be able to stay off opioids. Clonidine is especially helpful. It blocks that norepinephrine response so they don't feel so terrible. It does have some side effects, so it can cause, since, it brings down blood pressure. It's commonly used in blood pressure. And so it can have quite a bit of dizziness. Um, some other ones, again, these are off-label. Some of them are FDA approved, but still the off-label use exists. Naltrexone, both oral and injectable. The mechanism is relapse prevention. So we use it both in opioid use disorder and in alcohol use disorder. Alcohol, generally, I encourage Vivitrol, the injectable form, in the sense that it significantly reduces cravings and the amount of drinks that are used in between in between injections. If a patient doesn't want to take the injectable, then the oral medication is effective as well. The injectable Vivitrol can be very expensive, so that can be a hindrance for patients. There is some programs, especially in the Omaha area. I know UNMC has this, that if a patient ever starts Vivitrol, like in the hospital setting, that it's free for them And I believe either the second dose or maybe up to the third dose, they can have those three doses for free. Otherwise, it is quite expensive. And so maybe looking at the oral form is maybe better. But when we look at the research for this, naltrexone has the strongest support and it's pretty consistent. And so I commonly encourage anybody that has patients with alcohol use disorder. This is one of those medications that really encourage naltrexone. I know there's some caution where it's like, they're already using alcohol. Maybe their liver enzymes are already elevated, and naltrexone can certainly worsen that. There is that concern when a patient starts naltrexone, you maybe get liver enzymes just to kind of get a baseline. But I don't ever want that to be a hindrance for people for not encouraging the medication because they're already kind of at significant risk of alcohol related diseases, potentially cirrhosis. And so we really have to kind of look at the benefits and risks here. And when you look at the research to kind of support naltrexone, even if liver enzymes are elevated, the research does support still using it and then just kind of monitoring as long as it doesn't significantly worsen. It should actually improve, but as long as it doesn't significantly worsen, it can stay elevated but continue to closely monitor and use in alcohol use disorder. Some emerging therapies for alcohol use disorder. Some of the ones that have been the most studied are ones like baclofen, because it's a GABA B receptor agonist. Again, the results are mixed. I'm not eager to use it and jump on board to giving it to every patient with alcohol use disorder. Ondansetron, Zofran. It is a serotonin antagonist, and it does have the potential in early onset alcohol use disorder. There are very specific trials that kind of look at that very beginning period before patients really stop decreasing their use or drinking less. And so it does have good research in that initial period. Not a lot to support that post-initial or throughout. So that one is kind of back and forth, but the serotonin antagonists can be helpful. Memantine is an NMDA receptor antagonist. Again, there's limited data. Of all of them, baclofen does show the most promise, but again, there needs to be more studies to truly validate that research and to make it a primary treatment modality for alcohol use disorder. Stimulant use disorder, this is probably one of my favorite classes of medication because I just feel like there's a lot of potential there as well. But there's just not a ton of money or trials really going in to study this because the stimulants that we have on the streets and that patients are using are so potent and so powerful. It's really hard to mimic that effect in order to get them adequate treatment and being able to maintain abstinence off the stimulant. Some of the ones that are really key in the research are modafinil. Modafinil is a really, really interesting medication because we have an idea of how it works with dopamine and glutamate modulation, but we still don't truly understanding the full mechanism of action. And I think because of that, a lot of the studies, I mean, there's limited success with it. Some of the studies are great, actually. It shows that modafinil was really effective, but I mean, these are very controlled studies with very limited patients and with limited characteristics of each patient. I mean, so really it's hard to apply it to other cases. Bupropion, there is strong evidence to support cocaine and methamphetamine use, specifically with that norepinephrine and that dopamine effect that we get with buprenorphine, which both of those receptors are highly turned on both with cocaine and methamphetamine use. So it can also help with that withdrawal period as well. Methylphenidate, this is there is research to support that it is helpful in methamphetamine use disorder and cocaine use disorder. It can be risky though because it is a stimulant, and if we we are potentially dealing with solely just the substance use disorder and not underlying ADHD, or that's not the reason for the substance use disorder, then really we could just be applying the receptors with kind of that the the addiction that's kind of that they're looking for essentially. We're kind of feeding into it in a way. I do caution this mentality though. So I never want somebody to shy away from using methylphenidate for a methamphetamine use disorder or a cocaine use disorder. I always want all providers to really look and make sure that ADHD isn't an underlying issue and kind of driving that substance use disorder. Because when that is at play, then we do have the research is supportive in using something like Ritalin for the potential treatment. But I mean, the treatment is really the ADHD and not necessarily the substance use disorder, or it's a combination. This is where we do need more research to kind of support. Is this a standard protocol that we can use, or is it only in certain scenarios like ADHD, and we kind of treat both the ADHD and the substance use disorder? Cannabis use disorder, again, there's some evidence. We just need more of the studies to look at this. But it kind of listed some just to kind of give an idea that have been tried, like gabapentin is one that's in the research and reducing cravings and withdrawal. And acetylcysteine, also, I've seen kind of mixed results. And if it's going to be helpful with the glutamate modulation, if we actually get any abstinence with the cannabis use disorder. But I kind of just listed it here just to kind of give a brief overview of all the kind of substance use disorders. So the kind of the whole purpose of this is really looking at the research, and clearly with off labels medication use, it's so mixed. We just don't have enough research to support it as a standard treatment. And so when you kind of go in and look up your own research and if you have a certain patient and you kind of go into wherever PubMed or whatever to look up the research trials, really looking at what kind of evidence that you kind of want to look at to see if it would be helpful for your patient. So of course, randomized controlled trials, those are our gold standard. Meta-analysis, I commonly will check about once a month to see if there's any new ones that have been done to look at overall the off-label use in substance use disorders to kind of, it's basically like doing the work for you. Like, what's all the research that we have available that can kind of put it into an overall view of what can be useful and what cannot. But you got to take into account the small sample sizes. That's going to be the most important when you're applying it to your patient and the population, of course. So we just really need more of this real world evidence to say whether or not we can use this as a standard protocol. And once we have that, the FDA will generally come on board and approving for a standard protocol. But until we can get to that point, we won't really get that as a standard protocol. So that's where we're really using it off label. And so with that, with us not having that standard FDA approved protocol and using these off-label medication, it really comes down to balancing risks and benefits. And I know these are things that everybody knows when you're prescribing anything, but when we're doing it for substance use disorder, I really like to have a slide for this, really stress this, because documentation becomes exceptionally important. I've looked at cases that DHHS has asked me to review on treatment protocols, and it's generally always with substance use disorders that they have the questions about. And I generally side always with if the provider provided evidence to explain the rationale for using that medication to treat the patient, then that's really all that I'm looking for when I review these cases. A lot of times, though, that it's not there. And so I really like to stress this in these type of presentation, really making sure the documentation is there, and the transparency is there when you're discussing it with your patients. There's not a single time that when I've brought this forward to any of my patients when I'm treating their substance use disorder, where I've ever had a patient say, no, I'm
Looks like we may have lost Stephanie again. We'll just give her a minute. She may have to just log back on. She must have a bad connection over there. And I'm checking with Stephanie again here to see if she can hop back on. Here she comes.
Again, guys, I am
Eh,
so sorry. I am getting kicked out of the internet. I'm even at a hospital right now, so I'm gonna blame them. So
That's all right.
getting message that the internet's going down. So bear with me. Bear with me. Okay, let me bring this back up. Okay. So as I was mentioning, really having that transparency with patients that they truly understanding the risks and benefits. When that documentation is there, that's generally all you need to kind of support your decision on using a certain treatment or medication for their substance use disorder. And I always kind of mention the legal terms. I mean, it's the ethical duty to consider all the evidence-based options, have that discussion, and generally patients will be eager to try the medication if you feel that's the best for them. Some of the barriers to implementing these off-label medications, I mean, everybody's run into this issue, is insurance coverage. This is such a barrier. Thankfully, a lot of these medications, not all, but a lot of them are generic, not brand. So they're generally cheaper. That doesn't necessarily mean that insurance is going to cover it, but maybe if it's older medication, cheaper patients can afford it. But still, this is a concern. The cost is obviously a concern. Um, the hesitancy due to those legal concerns, as I was mentioning, is a significant problem, and also why we don't have a ton of research with it because of those legal concerns. The FDA isn't backing us and using it and making it approved. And because of that, there's always this kind of concern. Well, if it's not FDA approved, then I'm not even going to touch that because that's just a legal issue just waiting to happen. And the problem is then it becomes this, well, I'll wait for the FDA approval. Well, FDA approval is actually waiting for more use to show the consistent positive results with it. And so with this kind of mentality, I mean, eventually it just never gets approved and we're constantly using these as off-label. And so I encourage everybody, look at, as I kind of went through, I kind of tried to put a little bit of medications on each one, really look at the research, look at the trials yourself to get comfortable with it so that you do feel comfortable bringing it forward to your patient and using these medications. The fact that it's not FDA approved, don't let that be a barrier of stopping, just making sure that you have the appropriate conversation and the documentation to support it. And that's typically all you need. If it helps your patients get better and helps them, helps treat their substance use disorder, then that's ultimately, that's worth it. And so that's where I kind of put need for greater awareness and training. That's what we're doing here, is making sure that we put this kind of in the forefront of your guys' minds, because everybody sees substance use disorder in your clinic, regardless of what specialty you are. And by having this kind of fresh in your mind with these trainings, then it can increase the not only understanding but comfort in being able to have these discussions. Um, I believe in the next slide, I also have some specific studies, and I'll have these slides sent out to you so you guys have that as this as a resource. But some of the more success stories of our off-label medication is with gabapentin and managing our alcohol cravings. So again, this is not treating the substance use disorder, but the cravings are just as important because it's gonna dictate whether or not we have a period where they'll be able to kind of sustain and come up with a treatment plan, or whether they'll kind of go right back to using if they feel so terrible. And so managing those cravings, such as with gabapentin and alcohol cravings, we get improved patient outcomes. Again, as I mentioned, naltrexone and opioid relapse prevention, bupropion, tobacco cessation, these are our most successful medications that we use for substance use. So if you're using these already, great. And if they're working, that's fantastic. If you ever feel like they don't quite work just enough, then that's where we can kind of bring in some of those other medications that I discussed. Here's the slide I just wanted to kind of throw in so you guys have these trials that you can look at. These are probably the best trials that really looked at whether or not they would be helpful. And it's our gabapentin with alcohol cravings and withdrawal severity, topiramate, alcohol consumption. And then I also wanted to put one on baclofen of it can be helpful in just the high severity alcohol use. So I also listed that study down as well if anybody was interested in reading it to get more information on that. Some of our emerging therapies is our psychedelics, and this is one I'm actually quite excited about because the research that we have is quite positive. There's not a lot of research that says it doesn't work, which is awesome because we really don't ever see that in any of our medications, right? It's always kind of, well, these studies say no, these studies say yes. Our psychedelics have been overall really positive. There's not a lot because they are so highly regulated by the government itself and even being able to do the research. But the ones that have been able to do it successfully, they're all generally positive in using it for a lot of different diseases, including substance use disorder. So one of the newer studies was with psilocybin. There was a significant reduction in alcohol consumption. I mean, it was a significant, and it's extremely encouraging. Though I don't know if you can. This is one I'm really excited about. MDMA is also one that's actively being studied, and it's effective in reducing our PTSD-related substance use disorder symptoms, which is a very specific patient population, highly needed, very specific, and currently they're in the phase 3 trials, but so far the research is quite positive. And the reason why these are in the research now and why these are the kind of the forefront in looking at the treatment modalities is there's the potential for rewiring the neural pathways and emotional processing, which is a huge underlying issue in substance use disorder. So if we can rewire that neural pathway, then essentially we treat the substance use disorder, and that's amazing. And so I'm quite excited to see where research goes with this and getting more approval for other places to continue with the research so we can get all of those studies together to get the FDA approval. One of the challenges that we're facing now, since this is such a new treatment modality, is the long-term efficacy. So far, with what we've seen, generally they need, from the studies that I've kind of looked in, 1 to 3 treatments have been quite effective, but still we can't really apply that to long-term efficacy. I think the biggest trial that I saw was about a year, so still undecided if we can get that long-term efficacy. And without it, then we really can't get that approval by the FDA. So really, it just comes down to time and making sure that the research continues to kind of support that it would be helpful in substance use disorders. I mentioned a couple more studies, just so if you guys are interested in these things, these are ones that I would highly recommend looking into. For the psilocybin, it's NYU study. I believe it's still actively going on, but the one that they did with smoking rates, it had a 50% reduction in smoking rates at 12 months, which is huge. MDMA had, as I mentioned, sustained remission in the PTSD related substance use disordered cases. There are some studies also that showed combination therapies showing synergy with psychotherapy are helpful, which makes sense because this is what we've consistently seen with our research in general, that psychotherapy plus medication is superior to either just medication or just psychotherapy alone. That's consistent with what we're seeing with our psychedelics as well. And again, just the need for larger, diverse population studies. This is an area I'm actually actively kind of engaged trying to get something approved at one of the clinics that I'm at. It's a very difficult process. I guess I was naive on how difficult it is, but psilocybin and MDMA are so highly regulated by the government. Even getting approval for the research is incredibly difficult. But I think as more and more clinics and research facilities request this approval to start the research, then I think the FDA will kind of become more lax on giving that approval. And hopefully that if the research continues to be positive, then we'll get that FDA approval and maybe get this as a standard treatment modality for treating substance use disorder. So this is our future research. Hopefully it continues to be positive, but I just kind of always like to mention it. So as kind of something that really may be helpful for your patients in the future. So just a brief overview of what we kind of went over today. We're discussing kind of the off-label medications that fill these critical gaps in our substance use disorder treatment. We really just don't have a lot of standardized protocol treatment by the FDA. And so without that, it's providers can be very cautious in using them for treating their substance use disorder patients. It's important to always understand the mechanism of action and applying that to substance use disorder. Remembering that norepinephrine, dopamine, serotonin all play such critical components in the substance use disorder pathway in general, and making sure that we're choosing medications that kind of align with whatever specific substance use disorder that they are currently battling with. Again, research is ongoing. It's important to stay updated, and that's where we can be very helpful in bringing those updated research to you guys. And then, as I mentioned before, of course, ethical prescribing is key to patient trust. Be completely open and honest with them. Tell them exactly what, if there's only one study to support it, let them know that. Even in that case, patients generally will try it if the research if there's been some studies to say it can be helpful, they are looking for any type of hope. And so this can be very helpful and patients continuing to come back because they are well informed and they understand that this might not work or it might work. And so having that transparency in the documentation is especially important. And with that said, does anybody have any questions or any cases they would like to discuss?
Yeah, feel free to drop some questions in the chat, or if you want to unmute and bring a case forward, that's of course always welcome as well. We do have one question in the chat that I'll pose to you here, Dr. Bennington. This comes from Nathan. He asks an adjacent psychiatric question. What are your thoughts on acetylcholine as a treatment target in ADHD?
So, you guys can still hear me, right? Did I mute? No. Okay.
I can still hear you. Yep.
Okay. So, it can be, so there are some studies that show it can be helpful. For as standard treatment for ADHD, it has not been shown to be, as a primary treatment, it's not considered.
Stephanie, I'm sorry. That was my fault. I accidentally muted you. My bad.
All right, there we go.
Didn't mean
Are
to
we
do
good?
that. Yeah, we're good. Sorry.
Okay, so as a primary standard protocol treatment for ADHD, research does not support it, and the mechanism behind it is not supportive. It can be very helpful for treating some of the other aspects of ADHD, such as like nail biting, like skin picking, hair pulling. Sometimes you can get actually worsening of kind of those stimulatory traits of ADHD when a stimulant is added. A lot of times it helps, but sometimes a stimulant can kind of worsen it, and that's where I generally would add it on, and it can be very helpful. But as a standard primary treatment for ADHD, no, it's not helpful.
All right. Any other questions, comments, thoughts? cases. We've got about 15 minutes. Might as well use our expert panel's time while we have it. Give folks
Well,
just a
and if
minute or two.
anybody
Yeah, go ahead.
And if
Go
anybody
ahead.
has any cases, if it comes up later, you can absolutely always send it over to Will and he can forward it on to us. And if it's something like you either can email back or honestly, I'm always fine just giving a brief phone call if you list your number. I mean, that's what we're here for. And if you have a patient in your office and one of these thoughts come up, and you're like, I wonder if I wonder if, this medication would apply. I mean, you could quite literally.
Looks like we lost her again. But yeah, absolutely. Just echoing what she was saying about if you need interested in a case consult, just get in touch with me. Our experts are always happy to make a quick phone call to discuss those patient cases with you all. Um, we've got a few minutes. Any other questions for the team? I'll be sure to share Stephanie's slides with everybody today. While we're here, I'm gonna drop the link to the evaluation survey in the chat. So you can grab that. I'll also be emailing that link out in a couple hours this morning, so you can grab your CME certificate that way. I'm not seeing any other questions or comments, which which means we can just go ahead and end early today, I think. Unless we have anything else from the Echo team.
I have one thought,
Yeah.
but maybe I want to pull Mary in on this from her legal side. But and Stephanie touched on this, but when we're talking about like prescribing the off-label medications for substance use disorder, she mentioned like the documentation side of it, and so is it my question is like, is it sufficient just to say like, hey, there's been some studies and educate the patient on it, or is it like, do we actually have to document the actual studies in the note when things are being looked over? Like, how specific do we need to be? Part of my question stems from like, oh, Stephanie's back, great. All right, Stephanie, I have a sort of like a case and a question for you, but I was asking about being just like a little bit more specific on the documentation for off-label medications for treating like substance use, specifically like stimulants and things like that. Like, do we need to be documenting the actual cases in the note, or do we just need to be documenting like, hey, there's some cases that have been done, and here's the risks of the medications, here's the benefits. It's your decision to make that at this point. Is that sufficient in that?
Yep. Yeah, so you never need to document the cases and just say there is evidence to support the use of this medication for substance use disorder. I have tried these treatment modalities, still having significant issues, not having any improvement, still actively using. Discuss with patient that we are going to try this, given that there is research to support it. Discuss the risks and benefits. Patient understands that this, it could potentially lead to, cardiovascular risks, or could worsen this, or could have no effect on their substance use disorder. But they understand and they agree to try this treatment, and we'll do close follow-up to make sure that it's working. So you can be pretty broad. Don't need to cite specific cases, just saying that there is research to support it and that you discussed it. So nothing different than if you whatever treatment modality you would use for like hypertension if you're using something differently.
There's a question in the chat, but I'll follow up with a question on cocaine. But the question was, how long do you treat with naltrexone for alcohol use disorder?
So there's multiple studies that kind of say the period should be different in each clinic, and I'm sure Ed, you guys have a standard protocol as well. But generally, I always tell patients, 6 months is the minimum. A year is generally what I would like to see. I mean, if we need to continue that because they're continuing to have cravings, then I keep them on it. But that's how I kind of assess it, is like, where are we at? Like, are we having quite a bit of cravings still? Are we having triggers? And if so, absolutely stay on it. And a lot of times patients, if they've had such success with naltrexone, they will want to stay on it as well. It's been so helpful for them, and they're not going to want to come off of it, especially for having that fear that there could be that relapse. So 6 months to 1 year, kind of check in with both. And if it needs to be on indefinitely, then that's okay too.
Yeah, I agree with that. And with the Sinclair method, again, it's generally like 3 to 6 months is generally how long that will take patients. But usually we see patients sort of fall out of treatment with us as far as like needing naltrexone or Vivitrol around sort of the 6 month mark. They just kind of stop coming to us, you know. So that's generally how long it seems like patients stay on it with us. Um, Low dose naltrexone for pain control. I'm pushing that one to you, Stephanie. What are your thoughts on low dose naltrexone for pain control?
And this is where, our wonderful pain specialist would be the expert on this. I don't treat pain. So this is kind of outside my area of expertise, but I do know that there is some research that says yes, there's some research to say no. And I believe John discussed this during um, the last one that he did a few weeks ago. And Ed, if you have anything to add, I can't say yes or no on either way. Um,
Yeah,
yeah,
I don't really have a lot to add, but Shannon, we can just send that message to John and we can just put that in an email and he can get back to you. We'll
yeah.
be able to put that
He's
together for you. It's a good
there.
question.
His areas of expertise is pain management. So, I mean, he will be a wonderful. Um, he's the best person to be able to provide the best guidance on that.
Yeah, Shannon, I'll shoot an email out to Dr. Massey today, and I'll copy you on that, and we'll hopefully we get a response from him on that. There was one other question about naltrexone. If patients want to trial taper off naltrexone, what would that look like? Any thoughts on that?
Since they're on such a low dose anyways, I mean, a lot of times they just stop taking it and they're okay. I generally don't recommend that. I usually always try to, bring them down to 25 milligrams, if they will. But there's if you're looking for an exact taper off schedule, I would highly discourage anybody abruptly stopping. A lot of times they do it and they're okay, but highly discourage it. When I think about a taper off schedule, usually I go down to 25 milligrams for a few weeks, and then we kind of think about that, or even spacing it off by every other day too. It can be very helpful. So really it just depends on how they feel in between the days. If you do like an every other day kind of taper schedule, how are they feeling in between those days? And so really have to kind of individualize it to that patient. I have had some patients where they just abruptly stop it and they did well. I've had some patients that really needed to kind of go down to 25 milligrams and kind of breaking it in half. And they needed to do that for several months. And then they would go to like every other day schedule. Then I've had some patients where they just kind of went to an every other day schedule, then every 2 days, and then they just kind of stopped taking it after a few weeks. And Ed, if you guys have a protocol too, feel free to add that on.
Yeah, I don't necessarily think we do have a protocol. Yeah, I think that patients have stopped it right away and done okay. But yeah, I think it's good to
Mhm.
take it down.
Yeah, and yeah, they're pretty in tune to their symptoms, so they'll tell you, hey, I stopped it and I don't feel the best. Is something going on? Then okay, well let's try every other day, or let's try going down to like 25 and for a couple weeks, and generally they should do fine with that.
So, quick case for you, Stephanie. I actually just saw this patient the other day, but it was a patient that was struggling with like cocaine use disorder, sort of isolated, like no other substance use disorder. Um, and I think we were actually started her on like on some off-label like topiramate. Again, not a lot of great medications, but started her on that. And she's like coming to see me. I think it was like the third time to see her, but my first contact with the patient. But she's just like saying like, "Hey, I know I have a problem with cocaine. I have kids. I have a job. Like, I'm not trying to go to inpatient treatment. I don't really have time for contingency counseling." But she's like literally like begging me to prescribe her like a stimulant. And her argument is like, hey, I know what I'm using could be laced with fentanyl and I could die. And I know it's like really not good for me. And yet, like, it seems like my hands are tied from the stimulant side of prescribing for people with, methamphetamine or cocaine use disorder. I think we actually do have a protocol that's like our doctors can prescribe like methylphenidate maybe for some stimulant stuff, but like our mid levels can't, which again maybe just be like a legal side of things. But in those situations, like, is there anything different you would do, or what? How do you handle those sort of patient
In a
populations?
case where a patient is essentially almost begging for that stimulant because they're using this to function in everyday life, they need to get evaluated for ADHD. That's kind of the textbook like presentation where they come in, they're completely open and honest, very scared about what they're doing, obviously because the dangers of it being laced with something else. And it's essentially like, please, like this is like life or death for me. I quite literally can't function. They don't know why, but they quite literally can't function without it. The odds are it's ADHD, and the indication for a stimulant would be there. Generally when you add that on board, I mean, they don't then go and continue to use cocaine. They were self-treating essentially. And so when you actually give them the treatment that they truly need, I mean, you treated both. So I would absolutely start with the ADHD evaluation, and I would be surprised on that type of patient presentation on any of them not coming positive for ADHD.
And then, so like, if you saw a patient like that in your practice, you would evaluate them and possibly start them on something for that.
If
Um,
yeah,
that's
if I diagnosed them with ADHD, I would absolutely start them on a stimulant 100%, especially having that cocaine use disorder history. Or Strattera, Wellbutrin, none of that is going to work. They absolutely have to have a stimulant. And generally it's methylphenidate. It will work, not as great, but I generally go to the Adderall Vyvanse side to get more of the robust, the dopamine reuptake inhibitor, and then the increased dopamine release as well.
okay. It doesn't deter you if there's substance use. Like,
Nope.
I feel like we had like mental health providers for a while, and they're like, "Don't send me an ADHD or a methamphetamine patient that wants stimulants," But that was like our experience. But you're saying like that's
Yeah.
changing in ways of like, hey, we can actually
Yeah.
treat this. Okay.
And
So
and this is where I'm a huge advocate on that if they would have been treated for ADHD to begin with, then we wouldn't have the methamphetamine use disorder or cocaine use disorder. And so it's really a disservice to these patients because they've been functioning up to a point just trying to survive. They found some substance that's essentially self-treating their ADHD, but they understand the significant complications and risks associated with it. So they bring it forward open and honest, like, I know I shouldn't be doing this, but I can't survive without it. Please help me. And so not treating them, it would be harmful in that case. I mean, we absolutely have to treat them. And if there any provider anytime in their life would have treated them for ADHD to begin with, then you wouldn't have to be having that conversation with them. So yes, it should not ever deter you from treating them for their ADHD.
excellent. Thank you.
Yeah.
Well, I'm not seeing any more questions, so thanks everyone. Oh, and Stephanie, I was gonna ask if you could send me those slides. I'll
Yep.
send those out to
I will
everyone today.
do it
Some
right
great,
now so I don't
thank
forget.
you. Thanks. Yeah, some good information, resources on those. So yeah, like I said, we'll be back in January and February. So keep an eye out for some information about those trainings, and we'll hope to see you all back then. And then Echo Team, if you could just hop over to that other link for a quick team meeting, if y'all have time, we'll do that. Thanks, everybody.
Okay. Thank you, everyone.